Global Public Health Week 2026 is marked with the theme of Peace for Health, Health for Peace. We are reminded that strong, equitable, and resilient health systems are the foundation of thriving communities worldwide. Aligning with this vision, today's webinar focuses on prevention first, better oral health for all. Oral health is a vital yet often overlooked component of overall health and well-being. Oral diseases such as dental caries and periodontal disease remain among the most common and most prevalent health issues globally, often disproportionately affecting underserved populations. In today's session, we will explore how community-level prevention can reduce oral health inequalities. In a moment, I will introduce our three esteemed speakers, all of whom are also members of the Oral Health Working Group. The format for today's session will include presentations from our three speakers, followed by a question and answer segment. I encourage everyone to send in your questions via the chat box below. You can do it at any point during the webinar, and our panelists will address them at the very end. I am delighted to introduce our first speaker, Dr. Myron Allukian Jr., a senior advisor for the Federation's Oral Health Work Group, as well as the City of Boston Dental Director. A senior advisor for the Federation's Oral Health Work Group, as well as the City of Boston Dental Director for 34 years. Board certified in dental public health, he was the chair of the US Surgeon General's Work Group on Fluoridation and Dental Health for the 1990 Prevention Objectives for the Nation, now in Healthy People 2030, the National Health Objectives. A past president for the American Public Health Association, Dr. Allukian has been on the faculties of Harvard, Tufts, and Boston University Schools of Dental Medicine for over 50 years. He is also vice president of both the American Fluoridation Society and the American Fluoridation Institute, and a member of the National Academy of Medicine. He has been called the social conscience of dentistry. Welcome, Dr. Allukian.
Greetings from Boston, Massachusetts. Thank you for joining us in this panel. Tonight, I am going to have one of my greatest challenges. What I'm going to try to do in 15 minutes is take 60 years of my experience in dental public health and dentistry and give you three essential messages. One, why is community water fluoridation so important? Two, why it's safe and effective. And three, what can you do to make a difference to get community water fluoridation in your community, or if you do not have a public water supply, solve fluoridation. First, why is community water fluoridation important? Community water fluoridation is important because almost everyone has the disease, tooth decay. It affects people of all ages. For example, in the United States, for older teenagers, 67% have had tooth decay with more than 5 tooth surfaces affected. For those aged 50 to 64, 95% have had tooth decay, with 54 affected tooth surfaces. And for people over 65, roughly 17% have no teeth whatsoever. In the 50s, it was 50%. And thanks to fluoridation, thanks to fluorides, thanks to fluoride toothpaste, and thanks to prevention-oriented dentistry and dental hygiene, we have reduced dramatically the percentage of the population over 65 who have no teeth whatsoever. So, first, why is it so important? It's so important because not only does it affect people in the United States, but also internationally. The World Health Organization several years ago estimated there are 3.5 billion people in the world with active tooth decay. 3.5 billion people. And for the low income, their problems are much worse because they're not able to get the care and they're living with pain and infection. When I was a little child brought up in the inner city, I had a lot of tooth decay. And when my parents took me to the dentist, no anesthesia, slow speed drill, agonizing pain, agonizing pain. And I used to say to myself, how could someone have a job where they torture little kids like me? Years later, after orthodontics, I saw that dentists can be warm and friendly and not just inducing pain. Now, if I had been brought up in a fluoridated community, I would not have to have suffered like I did. But there are millions of people suffering, millions of children suffering because they don't have access to fluorides, fluoridation, and better prevention. The other problem we have in this country and worldwide is an addiction to alcohol, nicotine, sugar, fat, and salt, and especially sugar. The food industry is a $2.3 trillion industry, $2.3 trillion, and they spend $14 billion a year promoting and advertising their products. In the United States, we have some controls of the level of advertising in terms of children. Not enough, but we have some. But in developing countries, there are no controls. And in those countries, people eating more junk food, they're smoking cigarettes, they're using tobacco because they don't have the restrictions we have in this country. The average American consumes about 129 pounds of sugar a year. 129 pounds. 70 pounds of that is added sugar. That's more than 20 teaspoons of sugar a day. 20 teaspoons of sugar a day. And when you look at soda and soft drinks, the average soda has 10 teaspoons of sugar added to the drink. This is the challenge that we have in our country, and this is the challenge we have worldwide. Why is an oral health important? It's important because good oral health allows you to eat, chew, talk, smile, kiss, sleep, think, study without pain and infection. Good oral health can affect your social mobility, the types of people you meet, the types of people you interact with and marry, and it can affect the type of job that you may have. So that's why oral health is important. Now, let's talk about fluoridation. Why is fluoridation safe and effective? The nice thing about fluoridation is everyone in the community benefits. Whether it's water fluoridation or salt fluoridation, everyone in the community benefits. It's the one preventive measure we have that can make an impact on tooth decay, the most common disease. What is fluoride? Fluoride is a naturally occurring mineral compound in the Earth's crust. All water supplies have fluoride in them. Whether they're fluoridated or not, that water supply has some fluoride in it, whether it's central, natural, or whatever. There's always some fluoride. Not enough to prevent tooth decay, but there's always some fluoride in the water naturally. The ocean is fluoridated at approximately 1 part per million. The best way to treat a disease is to prevent it. And fluoridation is the foundation for better oral health in every community, in any community. And everyone in the community benefits. Everyone in the community benefits. I call it nature's way to prevent tooth decay. It has a cost-benefit ratio of roughly 1 to 20. For every dollar you put into fluoridation, you get $20 back in better oral health. It's a real bargain. It's a real bargain. Unfortunately, we have people in this country who promote junk science, try to confuse the public, finding ways to make money by attacking science and what we call fake news. What we call fake news. And this, since the beginning of fluoridation, there have been people who've been against it. They called it a communist plot. They said it's in rat poison. They said it causes cancer. And now they're saying it affects IQ. So we as professionals need to learn, how do we deal with this misinformation? When I was a senior at the University of Pennsylvania, senior year, we had one of our speakers spoke on fluoridation. I'm a senior dental student. So he's talking about fluoridation and the challenges. And I said to myself, has nothing to do with me. I'm going into practice. I'm going into private practice. Let other people do that. I had no idea what the dental needs were in the communities that I lived in. I knew I had problems. I didn't realize it was so widespread. And it wasn't until I got educated in public health that I learned it's a severe problem, and the best way to deal with it is with water fluoridation. Everyone benefits. We've had community water fluoridation in this country now for over 80 years. We have about 209 million Americans living in fluoridated communities. And worldwide, we have over 400 million people living in some 27 countries with community water fluoridation. Every country in the world has a health department. Every country in the world has a health department. They may or may not have a dental program or a dentist in the health department. In the United States, every state health department has an oral health division, and they usually have a dentist or hygienist trained in public health. Every country in the world should have someone who's involved in the Minister of Health's office, in the country's health department. They should have a dentist who's trained in public health. So they use a community approach to improving the health of the population. Next, please. Educate, educate, educate. These are the things, there are three things that you can do to educate the population. One is when you have a patient in the dental chair, you educate them as to the benefits of community water fluoridation. When you're involved with community groups or school prevention programs or parent-teacher groups, educate them about prevention. What works, what we know works, what's the science? You have to get the science across. You need to know the science. You need to get the community support. And what we want is that every child has the best oral health possible, and the best oral health possible is through prevention. Community water fluoridation, if you have a public water supply. Salt fluoridation, if you don't have a public water supply. School prevention programs with fluoride varnish, topical fluoride, and dental sealant programs. But you need to get a community approach. And you can't do that by yourself. You can't do that by yourself. You have to get other people involved in that so that they understand what needs to be done. Next slide, please. Educate, educate, educate. If you're in a fluoridated community, you need to educate the people in that community as to the benefits and how fortunate they are to be in a fluoridated community. So if someone challenges it with scare tactics, they'll have been well informed by their dental professionals and their dental provider. If you're in a non-fluoridated community, educate, educate your patients. Let them know they have unnecessary pain and infection and higher bills. A number of years ago, we did a study of legislators in Massachusetts, and we found that all of them went to a dentist on a regular basis. All of them went to a physician on a regular basis. None of their physicians or dentists ever said anything about fluoridation. But they got a lot of misinformation from anti-fluoridationists who were sending them junk science, et cetera, et cetera. And they would say, well, gee, how come the profession never tells me anything? But people in my community are telling me it's a poison, or it's a communist plot, or it's going to affect my kid's IQ. You have to educate the community, not only your patients, but community groups and organizations and legislators, people who are making the laws.
One more minute.
Next, please. Fluoridation benefits everyone. We have to educate everyone. We have to educate health leaders, public health leaders, legislators about the benefits of fluoridation. Just today, a new study came out in the Journal of the American Dental Association, which essentially, again, looking at the data, a new study, no relationship between IQ and fluoride, no biological mechanism for fluoride to affect the brain and affect IQ. When the first IQ study came out with fluoride saying it had a negative effect, I did meet with those individuals for a couple of hours. They did change their message a little bit, and I did go back to my office. And as I said before, I looked at what countries are 100% fluoridated. And there were only two, Hong Kong and Singapore. And both of them had the highest IQ in the world at that time. So in closing, fluoridation is safe and effective. There are 4 websites I would recommend for evidence-based information: the Centers for Disease Control, the ADA just came out last year with Fluoridation Facts 2025, very comprehensive, excellent information. The American Fluoridation Society and the Campaign for Dental Health, both of them are up to date in terms of some of the latest arguments against fluoridation and what the science and facts are. So in closing, we make a living by what we get. We make a life by what we give. We all have an opportunity to help improve the quality of life of our fellow countrymen, our neighbors, our families. Advocate, advocate, advocate. Educate, educate, educate. Thank you for your time.
Thank you very much, Dr. Allukian. That was a very informative presentation on the importance of community water fluoridation and the importance of overcoming misinformation for our patients and the community. All right, now I would like to introduce our second speaker. Welcome, Dr. Haewon Lee. Dr. Lee is an assistant professor and the director of the Global Maternal and Child Oral Health Center at Seoul National University. She's also a senior advisor to our own Federation Oral Health Working Group and obtained her doctorate in public health and Doctor of Dental Medicine at Johns Hopkins School of Public Health and Charles School of Dental Medicine, respectively. She's built her career around integrating oral health into maternal and child health systems in the countries that need it most. Welcome, Dr. Lee. I'll hand it over to you.
Thank you so much. Bye. Today, I would like to give you a short presentation on our statement, fluoride statement as a World Federation Public Health Association. This policy statement was received and voted and enacted as an official policy in 2025. So I'm going to present on that 2-page positional statement and the basis and reasoning why behind the positional statements. So this is the paper that you can find it online. It's on Population Medicine Journal, WFPHA positional statement, access to the optimal use of a fluoride for oral health as a fundamental public health measure. And we worked with our team on this 2-page statement. And it goes over a history of a fluoridation. Dr. Myron did a beautiful job giving you a layout and the reasoning and the science, the evidence on fluoride. And we summarized that on our positional paper. And we also cited the 2 Cochrane review, the scientific evidence, how community water fluoridation works to prevent dental caries, and also other forms of a fluoride and how WHO expands essential medicine list, including sodium fluoride, fluoride-releasing glass ionomer cement, and fluoride application like varnish and gel and toothpaste. And in 2024, we had a recent Cochrane review on water fluoridation, which affirmed the effect of water fluoridation and also recommended the method of delivery should reflect the context of the region. So this is from CDC, US CDC infographic, how fluoride works. Fluoride goes into tooth enamel structure and its resistance to acid attacks. And it also can remineralize early carious lesion, we call it incipient regions, and reverse the process before a full caries form. And WHO recommend the drinking water fluoride from 0.5 to 1.0 ppm and maximum 1.5, balancing caries prevention with fluorosis protection. So this optimal zone that I indicated as a green here, from 0.5 to 1.0, and US recommendation is 0.7, and then WHO recommendation as a maximum amount is 1.5. And if fluoride concentration is greater than its recommended level of 1.5 ppm, we call it as excess amount. In some part of a global regions, the natural water has high fluoride concentration, and it can elevate the risk of dental fluorosis and fluorosis if it goes over this limit. So if it's within this recommended limit and range, 0.5 to 1 or 0.5 to 1.5, then we can say it maximizes the benefit to protect dental caries, but minimize any risk that we concern only happen when it's at high concentration. So there are multiple ways to deliver fluoride. Community water fluoridation, as Dr. Myron explained in very details, it benefits all ages regardless of demographics. It really achieves health equity, one of the 10 global public health inventions that benefit the whole population. Salt fluoridation, we can consider that no healthcare contact needed. Fluoride toothpaste, widespread availability in many regions, but some regions can be challenging financially. Professional fluoride varnishes and gel, and silver diamond fluoride, which is one of the 3 essential dental medicine, and glass ionomer cement. And I want to highlight, before I close, I want to highlight on this slides that recently, a few months ago, December last year, the WHO published this amazing report, Global Curriculum Guide for Community Health for Workers. And it has a chapter on oral health. So this 100-page documents list out what community health workers should do and can do in terms of elevate and promote health for the people. And if you work in resource limited setting, you know who community health workers are. They are the community members, mothers, fathers, elders, community members who actually living in the community. And this is a snapshot that I got from this oral health chapter. Of course, they will learn about the basics of oral health, identify common risks and determinants, and also explain the importance of preventive measures for the community people, as we explained in the introduction. And look at this. This is my slides on the second page of this oral health chapter. Provide basic support for disease management, including self-management, counsel on daily oral hygiene, toothbrushing with a fluoridated toothpaste, general advice as oral diseases as NCD, apply fluoride varnish or silver diamond fluoride application for community health workers. That means a lot. We talk about this community-based approach to deliver fluoride. And the next question we ask is, who delivers this? Only dentists? Probably not. In the United States, the pediatrician and nurses can deliver fluoride varnish, and they can also bill for it because there is a claim code for that. And AAPD, which I'm part of it as a pediatric dentist, also released a guideline how to apply SDF and fluoride gel for non-dental health professionals, so that we can deliver fluoride varnish when children comes for vaccination visit, even before they make their first dental visit. So going back to our positional statements, what's our message? First, this World Federation Public Health Association statement closely aligned with other major health frameworks, such as WHO's Global Strategy and Action Plan released in 2024, the Essential Medicine List, the first 3 essential dental medicine all include fluoride, and also guideline for drinking water quality, which indicate the safe range of a fluoride level in the drinking water. So this is a recommendation, 2 simple but strong messages. Optimal access to fluoride is a public health right and constitute a basic right. So we should integrate fluoride program into universal health cover frameworks, targeting marginalized population. And secondly, all countries, all member states need to develop national fluoride guideline and policies, and countries should establish a context-sensitive, context-informed guideline that actually consider that country's or regional situation, because we have a different delivery method of fluoride. So not one size fits all mandate, and we will work with the community resources and context to develop such targeted fluoride delivering measure. So the key takeaway of my presentation, fluoride access is a public health right. Oral diseases remain the world's most prevalent, most neglected diseases. Fluoride safety and effectiveness at recommendation level is firmly established. And to measure that recommended level is not individual's duty. The community, the regional, local government, and national government should make sure that fluoride in the water is at the recommended level. And a spectrum of delivery method for context-specific, equitable implementation is the key for successful delivery of fluoride. And our association, World Federation Public Health Association, commits to oral health equity through evidence-based, community-informed fluoride policy. With that, I will conclude my presentation and take any questions at the end of our third presenter. Thank you so much.
Thank you very much, Dr. Lee. That was a very enlightening presentation on the fluoride policy statement and also how even non-dental community health workers can support and deliver different spectrum of fluoridation treatments. Okay, now I'm delighted to introduce our final speaker for the webinar. I'd like to introduce Dr. Irene Adhyatmaka. Dr. Adhyatmaka is a preventative dentistry advocate specializing in oral microbiome-based approaches to improve long-term oral and systemic health. Her doctoral research on dental immunization has been adopted into Indonesia's Ministry of Health Regulation, and she serves as the director of the Global Oral Health Interest Group at the Consortium of Universities for Global Health. Welcome, Dr. Adhyatmaka.
So today I will integrate what the 2 speakers has presented, and I will close it with dental immunization. So we already know from the both 2 speakers that fluoride works, but in the in the mouth, when we say oral health, it's not only about caries. There is another disease in the mouth that we call periodontal disease. And both of these diseases started from the biofilm. So when we use fluoride, we doesn't need changes in the behavior of the patient. We can just put it in the water, put it in the salt. But because it is not only about taking care of caries, we need to also taking care of the behavior. If we can take care of the behavior, it will ensure the environment of the oral is healthy, and then we can prevent the disease. So this is why we come up with the dental immunization. So dental immunization ideas is to start with risk assessment. So the community can, at the earliest possible, prevent the start of the disease. And even though there is a white spot lesion as the early sign of the disease, we can still have the second fence to stop the disease by doing the rebiosis of the oral environment and also the remineralization. If in any case the disease still progress, we still have the third fence to stop the progress of the lesion by applying a surface protections. In other words, we want to stop it from progressing into a cavity. So this is the concept of dental immunization, 3 fences, but also the first and the second fences will be done by the parents, the schools, the community. And the third fence will be done by the health provider. So talking about the risk assessment, number one, we can use what we call iron donut. In iron donut, we try to change from awareness into action and finally into ownership. So this is how iron donut looks like. When we fill it out, we can get a feedback because we cannot change behavior just giving advice. But if we can give personalized feedback of his current condition, then we can give advice. We give a menu so he can select what he is able to do, meaning he take the responsibility. We give the empathy to what he can do and what he cannot do. And lastly, we make sure that he is able to do the changes. So it is said that if we want to change someone, we cannot just give advice, but we have to give the whole set of starting from feedback until self-efficacy. And then the second, we need to make it visible because we understand the problem is on the biofilm. So by using the tools, we can then make the patient see which one is the caries risk, which is the light blue, and which one is the periodontal disease, which is the purple. So by making it visible, then the patient can take the responsibility, can take charge of their own oral health. And not only students, we also experience that teachers also want to be taught how to brush. And the second is when we already see the white spot lesion, we can still do remineralization and rebiosis of the oral environment so we can stop the damage from progressing. And by doing this, we need to involve the community. We need to teach the parents, the school teachers, what is white spot, how to see them, and how to tackle them. And the third is if we see the lesion still progressing, we can still have the third measure, which is the surface protection. We can use the fluoride varnish application that also containing calcium and phosphate. So we try to measure whether this dental immunization is successful or not. We use 3 indicators: whether it is easy to transfer, whether it is improving oral health, and whether it is creating ownership, even though we are no longer with the community. So this is the situation when we try to explain about the usage of iron donuts to the school children. I'm using the 3rd grade school children so they can do risk assessment to their 1st grade school children. They look very enthusiastic. And also we measure whether the community knowledge has been changed throughout the program. So after 6 months, there is a drop down. Those who usually drink soft drink after 6 months reduced from 47 to 3%. And those who like to eat candies drop down from 21 to 2% after 6 months. And also those who like to drink milk using bottles drop down to 1%. And we also try to measure whether this is reflected in the oral health condition by itself. So we measure the percentage children with decays more than 7. In 4 school, it reduces. Percentage children with permanent teeth decay in 4 school also reduces. Percentage children with dentally fit means if they have 5 decays, all 5 decays has already been filled. So this is the measurement of how successful the curative side. It's also increases. And lastly, we measure the percentage of caries-free children, meaning those without caries stay free caries until the next 6 months. So there is an increase of the caries-free children. We also measure the improvement in program acceptance. So this is 3 years old patient entering the dentist clinic, very afraid, crying. But once we open with dental immunization program website, he started to get excited, and finally, within 3 minutes, he opened his mouth. So we can see that using tools, it's improved the acceptance and cooperation even for a very small children. And this is the situation in the school setting where children showcasing the toothbrushing with the disclosing. And not only that, the school also learned that when they using bottle milk, it's will ruin their teeth. So in the school, they have an idea of making a bottle milk graduation, where the children need to surrender their bottle milk, and then the teacher will replace with a glass. So this is the initiative coming up from the community when they get the knowledge from us. So the adoption of the dental immunization has shown an increase year after year. It grew from none to 2,500 children in that one setting by the dental nurses. And the engine of this dental immunization is the ownership of the community. So in this picture, you can see that we are involving parents to applying the 3-tone disclosing gel. So you can see the face of the mother, very serious, understand what is happening. So if I can summarize what really matters, the 3 things we should remember if we want to stop the oral disease is number 1, stop early. Number 2, make it visible. And number 3, make it theirs. So it has to belong to the community. So
Coba
I will close with
yang di
this
dalam ada
video.
kumannya nggak? Coba singatin Kak. Waduh, si kakak baik banget nih.
Lagi yang di kanan, kiri, atas, bawah.
So I will conclude my presentation with a message: healthy smiles start at home. Thank you.
Thank you very much, Dr. Adyatmaka. That was a great way to end all our presentations on a real case scenario, the dental immunization project that you founded for community approaches to preventative oral health. We'll now move into the question and answer segment. We'll start off with any existing questions in the chat box, and if anyone else has any other questions, please do keep sending them through. So the question we have says, thank you very much for all the excellent presentations. Please give your expert opinions for the concern that sometimes health professionals, dental health professionals, are taking sponsorships or grants from non-fluoridation promoting organizations, which gives conflicting messages to the public. How about the ethical aspect of this scenario, and what type of actions can be taken to counteract this? Dr. Allukian, I might get you started to answer this first, and we might see if Dr. Lee also wants to say something.
There are some dentists who have made it their life work to be against fluoridation. I've met them. I've been at meetings with them. They make money doing it. My psychology professor used to say, it's better to be wanted for murder than not to be wanted at all. And I'm not saying that they're committing murder, but some people look for ways to get in the spotlight. And by being against something where the science shows the opposite, that may be their motivation, or they may need the money. It's unfortunate they do that. There are physicians who do that. There are dentists who do it. There are people, there are lawyers who do that sort of thing, and it's unfortunate that happens. And there's really not much you can do about it. But it's unfortunate that it happens. So I've been at meetings with those individuals, people like that, and talking to them is like talking to a wall. They could care less. They just want to do their thing, and they get their personal satisfaction out of it for whatever reason. It's unfortunate.
Thank you for that. Dr. Lee, I'm not sure if you have anything further to add on that specific question.
Myron said beautifully. I think one reference we can look up is WHO's guideline for donor. They have clearly indicated which entity that we can receive donation or grants and not. So that can be a reference. And the other one is sometimes we may not know the details of the grantor or donor. So I think it's our due diligence that we need to research on what kind of agency or entity make those grants out. So that would be our responsibility to look for it.
Thank you. I might ask Dr. Adyatmaka, I have a question for you. How is the dental immunization project similar or different from traditional dental prevention methods?
Thank you for the questions. It is a very important question. So, what is the difference? The traditional prevention activities that we used to know is like mass toothbrushing, right? Where you gather many children in the uh, area and then you teach them how to brush. But what happened then is there is no empowerment from the children because they cannot see. You cannot do something that you cannot see. So the difference in dental immunization is you make it visible. The problem, you make it visible. So you can measure the risk. The children know the risk. The parents know the risk. So they are more understanding of what they are doing. If they do not understand what they are doing, they just do it for the sake like celebration sometimes. So we are not doing the empowering job if we are just doing for the sake of the celebration. So this dental immunization is like a set. You cannot prevent just by coming hit and run. It has to be a set. So you have to start it with the risk assessment so the parents understand what are the factors about the child because every child is unique. They have a different set of factors. Once they understand, then we make it visible so they can see which are the problem. And then they can brush. They understand the pressure as well. Because if you cannot remove the color, means the pressure is not enough. So there are several functions of using the three-tone disclosing gels. And then we apply the prevention for the surfaces. But again, the difference is we are not just focused on the fluoride. Why we are not just focused on the fluoride? Because we understand that the chemical of what builds the teeth is not just fluoride. It contains more calcium, more phosphate, and a little bit fluoride, right? So in the protecting of the surface, we would like to incorporate the complete minerals for the teeth as well. So that's the difference. Thank you.
Thank you. A question for Dr. Allukian. What is the strongest evidence we have today that fluoride is safe and effective?
Well, we've had thousands of studies that shows that it's safe and effective. And then as I mentioned in my presentation, an article just came out today in the Journal of the American Dental Association. And the authors are Dr. Jay Kumar, who was the state dental director in New York, as well as California, a very esteemed epidemiologist, Dr. Stephen Levy at the University of Iowa, who's been studying fluoride his whole career, and Dr. John Warren, who's also an investigator. And it's essentially an update on community water fluoridation, children's exposure, and children's intelligence. The original studies that were done also included medical evaluations. In the Kingston-Newburgh study, they did medical evaluations. Before they did community water fluoridation, they looked at naturally fluoridated communities. Bartlett, Texas, high fluoride, 8 parts per million. They did autopsies and looked at the people there. But again, there's been thousands of studies over and over again, essentially showing it's safe and effective. I have a question for Dr. Heewon Lee, though. Heewon, you mentioned the community health workers doing fluoride varnish and SDF. Are there any states in the country that will pay community health workers for doing that in Medicaid? Do you know of?
I'm not aware of it for United States, right?
Yeah, in the United States.
I'm not aware of it yet. It is for now pediatrician, nurse, and physician assistants can apply fluoride varnish and SDF for pediatricians. And AAPD released a guideline like 3 years ago, but I haven't heard about community health workers applying fluoride varnish yet.
Okay, well, the question is, I don't know how many states in Medicaid pay physicians and PAs and nurses to do fluoride varnish and SDF. In Massachusetts, they do. We did a study in Massachusetts a couple of years ago in one of our community health centers, and we found that most fluoride varnishes for children 5 and under were done in the pediatrician's office in the community health center. And it's usually done by a nurse or a medical assistant or something. And then for children 6 and over, the fluoride varnishes were done in the dental program. This is in a community health center in Massachusetts. And Massachusetts does pay for fluoride varnishes by physicians and medical officers, but I don't know how many other states do that. And if you pay them, they'll do it. If you pay the physicians and the health workers to do it, it will get done through Medicaid. I can trust me on that.
Right. I think the best way to look up is Medicaid population too. If Medicaid, which covers essential dental care for all the children enrolled in Medicaid, if they designated non-dental professionals as a provider, I think that would be a great way to start, considering and being mindful about the state Medicaid coverage can be different for adults and pregnant women. But for children, I think that's a great way to start with.
In my opinion, sustainability of water fluoridation works best when it is a national legalized government program. Malaysia is one example. It is legally endorsed by Parliament since 1974 as first national prevention strategy. Today, 77% of those receiving piped water in the country receive fluoride. What is your opinion? What are your thoughts?
I agree 100%. If the national government of a country says we should have fluoridation, I mean, you protect the water supply so people don't get infectious diseases. It makes sense to that the country also includes fluoride in the water supply. Now, in the United States, the U.S. government doesn't have the authority to order fluoridation for every state. It's a states' rights issue, and every state has to determine themselves what they're going to do with fluoridation. Connecticut was the first state in the country that mandated fluoridation. So since 1965, most of Connecticut has been fluoridated. We also have 2 states because of the new administration. I'm talking the Trump administration and the Secretary of HHS, Robert Kennedy Jr., who've been against fluoride. We have 2 states now that have banned fluoridation. One is Florida, and the other is Utah, and there are others considering it. And it's unfortunate because when you have someone in a leadership position like that, even though they say things that are completely untrue, some people believe them. And when they believe them, they go ahead and take action on it. So there's a lot of misconception coming out of the leadership in the federal government today, not only about fluorides and fluoridation, but also immunization, measles immunization, making claims that it causes autism. There's no scientific data that shows that the measles vaccine causes autism. But because the Secretary of HHS has said that, who's not a physician, no real health background, he's a lawyer, because he has said that, people are no longer getting measles vaccine. So what's happening? People are getting measles, kids are getting measles, and some children are dying. And it's unfortunate that our country has leadership that does not believe in the science. They defunded the National Institutes of Health quite a bit. They eliminated the dental division at CDC. There's no oral health division now at CDC. It's they're doing a lot of damage to the public's health.
Thank you. Excuse me, Dr. Adhyatmaka, I believe you might be good to answer this question. Can you compare the benefit of fluoride on developing dentition versus the topical effect on existing dentition?
So the difference between the developing dentition and the mature dentition, number one is also about the environment. So both fluoride can take effect in the same manner, but we have to be very careful for the younger age because the dosage cannot be the same with the adult. So there is a critical dosage of fluoride that probably Hewon has just mentioned in her presentation. But this is what we need to be mindful that the younger group age will receive lesser dosage of fluoride while the adult can receive higher. Also about the frequency, the adult and the younger groups will be also different based on the risk.
Thank you.
I'd like to respond to that question also.
Yes, please.
The nice thing about fluoridation is while the teeth are growing and developing, the fluoride becomes part of the enamel and makes it much stronger. Then once the teeth are up, there's also a topical benefit from community water fluoridation. If in addition you get a topical fluoride treatment, then you have even more prevention against tooth decay. The only problem with topical fluoride treatment is how do you get, if you're a country of 100 million people, how do you get 30 million children to get a fluoride treatment twice a year? Whereas if you fluoridate, you got to get a benefit. So the logistics of getting a total population to get topical fluoride on a regular basis is enormous. But if you're fluoridated, then they're automatically going to get the benefit. So there's the practical component. If you get both, then you're even better off. We did the first enamel fluoride biopsy study many years ago. And what we found was that children in a fluoridated community had roughly 600 to 800 more parts per million of fluoride than children in the non-fluoridated community. But children in the non-fluoridated community still had hundreds of parts per million of fluoride in their teeth because all water supplies have some fluoride, but not necessarily enough to prevent tooth decay as much as possible.
You need to clear your throat.
Thank you for that.
And you need to speak
We
slowly.
are nearing the end of our allocated time. So I would like to extend our gratitude to all three of our panelists for sharing their knowledge today and enriching our understanding of preventative oral health. Dr. Allukian covered the important topics of not only advocating for community water fluoridation, but also addressing the prevalent misinformation that exists to this day regarding fluoride. Dr. Lee discussed the fluoride policy statement that can be used to advocate for fluoride as a basic public health right across various geographical contexts. And Dr. Adhyatmaka wrapped that all up and showed us a real-life case study, her dental immunization project, which was a school-based approach to deliver fluoridation treatments and preventative oral healthcare to the community. I believe everyone will agree that the diverse perspectives and experience of our panelists has invited us to rethink the lens of oral health prevention by prioritizing accessibility, equity, and scalability.